picture the scenario. It's Tuesday morning, you're in the clinic, and you've got a pathology report in front of you. Cutaneous squamous cell carcinoma. It's early stage. It's on the cheek.
I know exactly where this is going.
Of course you do. Your hand is already moving toward the referral pad for Mohs micrographic surgery. It's almost Pavlovian at this point, right?
Good.
It's the face. It's SCC, so you do Mohs. It feels like the moral choice. It's precise, it spares tissue, it's the gold standard.
And nobody wants to be the clinician who did less than the gold standard. I mean, that is a very, very powerful driver in modern medicine.
Exactly. But that is the uncomfortable wedge we're trying to drive into the conversation today. We're looking at the current clinical consensus and asking a pretty rude question. Is that reflex actually wrong sometimes? Are we deploying a tank to kill a mosquito? Or, maybe more accurately, are we sometimes deploying that tank when a sniper rifle or even just a standard infantry unit would get a better outcome for the actual patient?
It's the quintessential tug-of-war in dermatologic surgery right now. We have this incredible hammer in Mohs micrographic surgery. I mean, 100% margin control, tissue conservation. It's a brilliant hammer.
It is.
But we're operating in a world where not everything is a nail.
Yeah.
And if you treat every SCC like it requires microscopic mapping, you aren't just wasting resources. You might actually be missing the biological forest for the trees.
So that's our mission today. We aren't questioning if Mohs works. We know it works. We're looking at the decision matrix.
Yeah.
We want to find the line where that Mohs reflex stops being good medicine and starts being, defensive medicine.
Yeah.
Because the goal here is precision, not just in the surgery itself, but in the decision-making process before the scalpel ever touches skin.
Right. It's about matching the procedure to the pathology. It's biology versus geometry.
I love that. Biology versus geometry. Okay, so let's start with the geometry part. Let's establish the sweet spot based on established best practices. Where's Mohs the, do not pass go, absolute winner?
The default posture, the scenario where the evidence is really the strongest, is specifically for adults with early stage, low to intermediate risk cutaneous SCC. And specifically when it's located in cosmetically or functionally sensitive areas.
The high-rent districts of the body, as we sometimes call them?
Exactly. But let's be specific for the clinicians listening. We're talking about the central face, the H zone, so ears, eyelids, nose, lips, and parts of the neck.
Okay.
In these locations, the primary currency is tissue preservation. You simply don't have the laxity to take a blind 4 or 6 millimeter margin without causing some kind of functional defect, pulling an eyelid down, distorting the lip.
And the data supports Mohs here definitively.
It does, but with a caveat we'll get to, the primary benefit is really twofold. First, recurrence. In this specific cohort facial, early-stage Mohs reduces the risk of recurrence significantly compared to standard-wide local excision.
Right.
We are looking at cure rates that are often cited above 97, 98, even 99%.
Which is the headline statistic everyone clings to.
Of course. And the second benefit is the cosmetic outcome. Because you're tracing the tumor out to its roots, you aren't taking dog ears or extra healthy skin just to be safe. Smaller hole, smaller scar. That matters immensely on the nasal ala.
Okay, I want to pause you there. Because looking at the methodology behind these recommendations, there's a phrase that pops up about the strength of this recommendation. It said the confidence level is moderate.
It catches people off guard, doesn't it?
It does. I mean, we talk about Mohs like it's a law of physics, but moderate confidence implies there's some wiggle room in the data. Why isn't it high confidence?
It's a research design issue, really. We lack massive randomized controlled trials that pit Mohs against standard excision head-to-head for every single anatomical site in a prospective way. Most of the data is observational.
I see.
So while the signal is very strong that Mohs is better for the face, it's not a mathematical certainty in the way, say, a pharmaceutical drug trial might be.
So we can't just feed the pathology report into an algorithm and have it spit out surgery A.
Exactly. We still have to think. And this is where the trade-off conversation begins. Because Mohs is resource intensive. Not just in dollars, but in time, in personnel, in opportunity cost.
It's that heavy artillery concept.
Right. Standard excision takes what, 20, 30 minutes?
Something like that.
Local anesthesia, cut, suture, done. Mohs is a half-day affair. You have a histotech, a lab on site, specialized surgeon, multiple stages of waiting. So if you have a low-risk SCC on the middle of the back.
Right, where you've got acres of skin to borrow from.
Precisely. Does that patient need the heavy artillery? Usually, no. If you can take a standard clinical margin, say 4 to 6 millimeters, and close it primarily without distorting anything, standard excision is arguably the superior choice.
Hold on, I want to push back on superior. That's a bold word. If I'm the patient or even the referring provider, I'm thinking, I don't care about the scar on the back. I just want the highest cure rate. Doesn't Mohs technically offer a higher cure rate even there?
Theoretically, yeah. Maybe by a fraction of a percentage point.
Fine.
But clinically, the difference is negligible for these low-risk tumors. This is where we have to separate biological cure from procedural overkill. If standard excision cures 95 or 96% of low-risk trunk tumors, and Mohs cures 98% but costs 4 times as much and takes 5 times as long, is that extra 2% worth the resource drain?
It's the law of diminishing returns.
And its opportunity cost.
Yes.
This is the part we often forget. If your Mohs surgeon is tied up for 4 hours chasing a superficial SCC on a guy's shoulder, they aren't treating the lady with the aggressive tumor on her eyelid. We have to look at the system.
Okay, so we have the sweet spot for the face and the efficiency spot for the trunk and low-risk areas. But biology is rarely that polite. I want to move to the danger zone.
The high-risk cases. This is where the decision matrix gets really messy.
Yes. Because there's a very dangerous assumption I see referenced constantly. It's the idea that Mohs is the end of the line. If the tumor is bad, you do Mohs, and if Mohs can't fix it, well, then nothing can.
That is the superiority trap. And it's dangerous because it ignores tumor biology.
Unpack that. When does the Mohs instinct actually fail us because the tumor is too dangerous? What are we looking for on that path report?
We're looking for aggressive histologic features. And we aren't just talking about size here. We're talking about poor differentiation. We're looking for perineural invasion, specifically involving nerves larger than 0.1 millimeters. We're looking for depth of invasion beyond the subcutaneous fat or, desmoplastic growth pattern.
Okay, so why does Mohs struggle there? Mohs is about checking 100% of the margin. Shouldn't it be better for those tricky features?
Here's the nuance. Mohs relies on the assumption of contiguous growth. It assumes the tumor is like a root system that stays connected. You cut, you check, you trace the root.
But high-risk biology doesn't always play by those rules.
Exactly. When you have those aggressive features I mentioned, like extensive perineural invasion or microsatellites, the tumor might exhibit skip lesions.
Skip lesions. That's the nightmare scenario.
It is. The cancer effectively jumps the fence. You might have a clear margin on your frozen section in the Mohs lab, but the cancer has tracked up a nerve bundle and is sitting a centimeter away, totally disconnected from the main mass. Or you have in-transit metastasis.
So in that specific scenario, Mohs gives you a false negative. You think you're clear, but you're not.
Correct. And relying solely on Mohs, because it's the gold standard, can give a really false sense of security.
So for these patients, the ones with the large, aggressive, nasty tumors with desmoplasia or nerve involvement, the decision isn't just Mohs versus excision. It's Mohs and what else?
Precisely. It requires a multidisciplinary mindset. You might need Mohs to clear the local bulk, sure, because it preserves function, but then you need to be thinking about wide local excision with permanent sections in an OR to check a wider field. You might need adjuvant radiation therapy. You might need to involve head and neck surgery for a sentinel lymph node biopsy.
It sounds like the danger here is hubris. Thinking the microscope in your office can see everything, even things that aren't physically connected anymore.
It is. And that brings us to the biggest wild card in this entire data set, immunosuppression.
This was the part of the clinical review that really struck me. The rules seem to completely change when the immune system is offline.
They do. The immunosuppressed patient, we're talking solid organ transplants, chronic lymphocytic leukemia, or patients on high-dose chemo or chronic biologics, they're living in a different biological reality.
How so? Is the surgery harder?
The surgery is technically the same. The cutting and sewing, that doesn't change. But the behavior of the enemy changes. In an immunocompetent person, your immune system is helping the surgeon. It cleans up microscopic debris. It fights field cancerization.
It's the cleanup crew following the surgeon.
Exactly. But in a transplant patient, you don't have that backup. The host defense mechanisms are gone. And this means two things. One, the tumor is likely more aggressive than it looks. And two, the field effect is rampant.
So a clear margin means less.
It means significantly less. You can get clear margins with Mohs, and the tumor can still recur at a much higher rate.
Mm.
Or you get what we call the whack-a-mole phenomenon. You clear one SCC, and 3 weeks later, another one pops up right on the scar line.
Because the entire field of skin is unstable, it's not just a focal problem anymore?
Exactly. So for these patients, the decision isn't just about the surgical technique, it's about surveillance. We need to reset expectations. We can't promise these patients one and done.
Huh.
We have to promise them we are watching you like a hawk.
So relying on Mohs as a set-it-and-forget-it solution for a transplant patient is basically malpractice.
I would agree with that. It requires intensified surveillance. We might need to involve their transplant team to discuss lowering their immunosuppression, if possible. We might need to start chemoprevention with azithromycin or nicotinamide. If we just treat them like a standard immunocompetent patient, we are failing them.
Speaking of expectations and failure, there's a fascinating point in the guidelines about how we interpret a bad day in the Mohs unit. You know the scenario. You tell the patient it'll be a morning procedure, but then you're on stage 3, then stage 4, then stage 5.
And the patient is looking at you with terror. Why didn't you get it all? Is it spreading while we speak?
And the surgeon is sweating, thinking, am I failing here? Am I missing the margin?
But the guidance suggests a crucial reframing here, that multi-stage day isn't a procedural failure. It is a diagnostic success.
That's a great line. Explain that.
The tumor is revealing its true nature. It looked like a pebble on the surface, but Mohs revealed it's actually an iceberg. The fact that it took 5 stages to clear tells you that this tumor has subclinical extension. It's deceptive.
So the number of stages is actually a risk factor itself.
Yes. If a tumor requires multiple stages, that is an independent predictor of future behavior. It shouldn't just be a sigh of relief when you finally get a clear slide. It should be a red flag that says, this patient needs closer follow-up.
It turns a frustrating afternoon into a data point. I like that.
It also protects the surgeon's psyche. You aren't failing. You are uncovering the truth of the pathology.
Now, I want to circle back to the practical side. We've talked about biology. Let's talk about the human beings attached to the skin, the patient-centered constraints.
This is the pitfall section.
Right. Because sometimes the best treatment on paper is the worst treatment for the person in the room.
Oh, we see this all the time. A clinician looks at a 90-year-old patient with dementia, severe kyphosis curved spine, can't lie flat, and a low-risk SCC on the cheek. And they push for Mohs because, well, it's the face, and Mohs is the gold standard.
But that patient has to lie still for 4 hours.
It's torture for them.
Yeah.
It causes agitation, pain, anxiety. And what if they have to travel 3 hours to get to the Mohs center? In that scenario, forcing the superior surgery is actually poor care.
So what's the alternative? Do you just leave it?
No, but you adapt. A standard excision done quickly in the local office with rapid closure might be the better medical decision. Or even destruction via curettage and electrodesiccation if the lesion is superficial enough, accepting a slightly higher recurrence rate for a massive gain in quality of life.
Because better implies holistically better.
Exactly. If the logistics of Mohs create a barrier to care, meaning the patient puts it off or cancels or suffers through it, then you failed. Standard excision is not a consolation prize. It is a valid, responsible surgical treatment when the context demands it.
I want to touch on one more trap before we wrap up. The numbers game. We love our margins. 4 millimeters, 6 millimeters, 2 centimeters.
The illusion of safety in numbers.
Is there a danger in being too rigid with these measurements?
A huge danger. The guidelines warn against using unvalidated numeric thresholds. You can't just say, oh, this tumor is 1.9 centimeters, so I'll excise it. But if it was 2.1 centimeters, I'd Mohs it.
Biology doesn't care about the metric system.
It really doesn't. You have to look at qualitative triggers. Is the border distinct? Can I see where the redness stops and the white skin begins? If the borders are vague, I don't care how small it is, that's a high risk for excision failure. That needs Mohs or a wider margin with permanent sections. If the borders are punched out and clear, you can be more confident with excision even on a larger lesion.
So look at the skin, not just the ruler.
Always. Treat the patient, not the caliper.
All right, let's try to synthesize all this. We've covered a lot of ground, from the H-zone to the immune system, from skip lesions to kyphosis. If a listener is driving to the clinic right now, what is the golden rule they should have in their head when they see that next SCC?
Okay, if I had to distill it into a flowchart, start with the instinct. Prefer Mohs micrographic surgery for adults with early stage, low to intermediate risk SCC on the face. That is your baseline. It maximizes cure and minimizes scarring. But you have to actively look for reasons to deviate. Don't autopilot.
Okay, what are the deviations?
1, is it low risk and on the body? Deviate to standard excision for efficiency and resource stewardship. 2, is it extremely high risk or is the patient immunosuppressed? Deviate to a multidisciplinary approach because Mohs alone might not be enough to catch those skip lesions.
And the third?
And 3, does the patient have constraints, health, travel, anxiety, that make Mohs a burden? Deviate to excision as a compassionate, effective alternative.
I love that. The instinct gets you to the neighborhood, but clinical judgment finds the house.
I might have to steal that metaphor.
It's yours. Before we sign off, I want to leave the listeners with a final thought to chew on. We talked about the gray area earlier.
The uncertainty gap.
Yeah. We can look a patient in the eye with an early-stage facial tumor and promise them with high confidence that Mohs is their best shot. We have the data. But for those high-risk, complex, immunosuppressed patients, the ones who need us the most, we actually have the least definitive promises to offer.
That's the irony of oncology, isn't it?
It is. The data doesn't promise a perfect cure there. So the challenge for you, the listener, is how do you communicate that? How do you be an honest broker of risk without taking away hope? When the gold standard isn't a guarantee, you stop being just a technician of the skin and you have to start being a doctor.
That's the art of medicine. Navigating the ship when the map runs out.
Indeed. Good luck on your rounds today. Thanks for listening.